Respiratory regulation. Now, there are two different things that are regulated as far as the respiratory system is concerned. Now, obviously, your respiratory rate, your what we call alveolar ventilation, how much air is going in and out of the lungs, how much air is going in and out of the alveoli. So that's one thing that's controlled. But the other thing is what's called lung perfusion. How much blood is being sent to the alveoli? So you got two different things to think about here. Think about this being an alveolus. This being capillary. So, controlling how much air is going in and out of here, how much blood is going through here. Cool? Okay. Now, blood flow. This is a pulmonary capillary. Now remember, the job of the pulmonary capillary is to pick up oxygen and deliver CO2. Right? That's the opposite of every other kind of capillary. The systemic capillaries, their job is to deliver oxygen, pick up the CO2. Okay, so you got to keep that in mind. This is the pulmonary capillary from the pulmonary arteries, carrying oxygen, pour blood from the right side of the heart to the lungs. Okay. Now, in systemic capillaries, all the other capillaries, peripheral systemic capillaries, if the PO2 is low, which is what y'all were just telling me about hemoglobin, the precapillary sphincter relaxes so that more blood flows into those capillaries, more oxygen can be dropped off. The opposite happens in the lung tissue. In other words, if the level of oxygen is low, there's no need to send blood to that alveolus because it's going to be difficult for oxygen to diffuse into the blood. So, the precapillary sphincters, controlling the capillary bed around this alveolus, those precapillary sphincters are going to constrict. Blood will be shunted to the alveoli where there is a lot of oxygen. It's just like in peripheral tissue, the blood goes to where the tissues need it.
Right. That's what I was wondering with the lung. Is that?
It's the same kind of thing. It's that local regulation to make it most efficient, to get the most oxygen. Thank you, would you teach this? I'm tired. Get the most oxygen into the blood the quickest way. Exactly. That's what we're talking about. So it's just that in the lung tissue, the precapillary sphincters respond opposite direction, and that's one part. You got to remember what's going on here. This is external respiration, as opposed to peripheral or systemic. That's internal respiration. Now, alveolar ventilation, this depends on the CO2, the PCO2. If the PCO2 level is increasing, that means that blood has come by, it's dropped off CO2. We got to get rid of the CO2. Now, the bronchioles that are delivering air to this alveolus, the smooth muscles around those are going to relax. So in this case, PCO2 makes the smooth muscles relax. More air flows in, more carbon dioxide is taken out. And the opposite, of course, is true. If the level of CO2 is low, there's not been a lot of CO2 dropped off, then these bronchioles will tend to stay constricted so that the air is shunted to the alveoli where the CO2 is high. And so it's a very nice auto-regulation, local regulation of airflow in and out of the lungs, as well as blood flow in and out of the pulmonary capillaries. And again, it's an efficiency issue. Send the blood where it can pick up the most oxygen, send the air where it can suck up the most CO2. All right, so that's local control. Each little capillary bed around each little alveolus. But systemic control, of course, goes back to the autonomic nervous system. When we talked about controlling the cardiovascular system, we were talking about the medulla oblongata, right? You had the cardioacceleratory center, you had the cardioinhibitory center, you had the vasomotor centers. All of those things were in the medulla oblongata. Respiratory system is controlled by centers in the medulla as well as centers in the pons. So you've got two different areas of the brain controlling respiration. So down here you've got what are called the medullary, and refers to medulla, medullary rhythmicity centers, the dorsal and ventral, dorsal being on the back side, ventral being on the front side. And then here in the pons, on the very back side of the pons, almost in the midbrain, you have the Pneumotaxic Center and the Apneustic Center. Basically, these guys are sending impulses directly to the respiratory muscles, the diaphragm, the internal, the external intercostals, yada. These guys influence what these guys do. So, the medulla oblongata is basically where the pacemaker for the lungs is. Remember that the heart, the SA node within the heart is its own pacemaker. The heart has its own pacemaker. But the lungs do not. Basically, the diaphragm does not. The diaphragm is a skeletal muscle. It must have a signal from the nervous system in order to contract. The cardiac muscle doesn't have to. So, the dorsal respiratory group is functioning all the time, basically. The ventral respiratory group only functions when you do forced breathing. For instance, when the doctor says take a deep breath, that's when the ventral respiratory group kicks in. Makes sense? When you're just doing quiet breathing, it's the dorsal respiratory group that's setting up the rhythm. All right, so how does this work? The dorsal respiratory group sends motor neurons or controls the motor neurons to the diaphragm and the external intercostal muscles, your inspiratory muscles. The VRG controls the extra ones, like when you take a deep breath, your abdominal muscles, the scalenes, the sternocleidomastoid, those things that really enlarge the thoracic cavity. During breathing right now, when you're not thinking about it, don't think about it. Don't you hate that? You can't talk about it without thinking about it. The dorsal respiratory group sends an impulse for 2 seconds, and then it stops for 3. So, quiet breathing, inhale for 2, diaphragm relaxes, exhale for 3. So, dorsal respiratory group, fires for 2 seconds, stops for 3. Fires for 2, stops for 3. So, it's just like in a car, mashing the accelerator and then taking your foot off. Now, what's the average respiratory rate? Breaths per minute. I know? 13? Yeah. 12 to 20, 12, 15, something like that. So if you think about 5 seconds, inhale for 2, exhale for 3. 5 goes into 60 how many times? Now, if you take a deep breath, or if you're talking, or if you're singing, and again, remember, you're not thinking about this consciously. This is brainstem. Okay, it happens automatically. Then the DRG fires, but then the VRG also kicks in. You would inhale longer or deeper. You're going to be taking more air into the lungs. If you're going to blow up a balloon. So that's how that works. Now, forceful exhalation. The dorsal respiratory group stops. The ventral respiratory group sends signals to the expiratory muscles. So, quiet breathing, DRG is firing for 2, relaxing. Forceful inhalation, the DRG and the VRG fire. Forceful exhalation, the DRG stops, the VRG continues to fire, but to a different set of muscles. Basically, as I said, the Apneustic and Pneumotaxic areas, these guys basically influence, help control what these guys are doing. So, depending on what other signals, for instance, if you're talking, if you're singing, if you know you're going to blow up a balloon, you've got the Cerebral Cortex sending signals to the pons. Depending on the pH of your blood or the temperature of your spinal fluid, depending on what sensory information is coming into the brainstem, that tells these guys what to tell these guys. The Apneustic Center basically promotes inhalation. The Pneumotaxic Center can inhibit the Apneustic Center. So this guy stimulates this one. This guy inhibits this one. Now, DRG, normal quiet breathing, fires for 2, doesn't fire for 3. If this guy activates this guy, stimulates this guy, you're going to inhale for longer. It's going to fire longer, you're going to inhale for longer. Make sense? Okay. So the AC, the Apneustic Center, promotes inhalation. The Pneumotaxic Center basically promotes exhalation because it inhibits inhalation, because it inhibits the Apneustic Center, and therefore not as many signals are getting sent to the dorsal respiratory group. So if signals come in and stimulate the Pneumotaxic Center, the Pneumotaxic Center says, all right, stop what you're doing. Don't do that. And what it does, since this is going to fire normally, or fewer signals are being sent, so this even fires less than normal, you can increase rate of respiration, but not depth of respiration. So it all depends. You have many breaths, but they're shallow. If signals come in to, if less signals are coming into this area, then it's not inhibiting this, and so this can continue to send signals to this. And so you have fewer breaths per minute, but they're deeper breaths. So quiet breathing, what's firing?
The dorsal.
Yeah, DRG, dorsal respiratory rate. Forced inhalation, the DRG and the VRG. Forced exhalation, the VRG. The signals into the ponds can stimulate the AC, which makes you do what? Basically inhale. Longer and deeper. Inhale longer and deeper. Signals into the PC inhibit the AC, and so you can breathe regular or even shorter. Inhale short. So now we've got local control, now we've got systemic control. Yeah, reflex control. Go back to a couple of my favorite two things. The Chemoreceptor Reflexes and the Baroreceptor Reflexes. These are the same reflexes that we talked about when we talked about regulating cardiovascular system. We're just looking at it from the respiratory systems. So, chemoreceptors are still monitoring carbon dioxide levels, hydrogen ions, pH, and oxygen levels. You've got the central chemoreceptors, which are actually in the medulla oblongata, and then you've got the peripheral chemoreceptors, which were the ones we talked about before, the ones that were in the carotid arteries and the aorta. So, the chemoreceptors are monitoring the chemical conditions in both the blood and the spinal fluid. So, the point being that these chemoreceptors, not only are they sending signals to the cardiovascular centers, but they're also sending signals to the respiratory centers. And then you've got the central chemoreceptors that are basically down here, kind of back here close to the where the fourth ventricle is. That's two laterals, third, and the fourth ventricle here, right at the backside of the medulla oblongata. So they can monitor what's going on in the spinal fluid. All right. Now, interestingly enough, the chemoreceptors in the brain, they are stimulated mainly by CO2. And of course, if CO2 goes up, pH goes down. Not by, now this doesn't make sense because you would think, well, the brain should be concerned about oxygen, right? Breathing is controlled mainly by the level of CO2 in the brain. Why do people drown? Has nothing to do with the oxygen. What happens is, when you're underwater, if you can't swim, you're instinctively going to hold your breath, right? The oxygen level is going to drop. Now, the oxygen level will drop enough that you pass out, but even before that happens, the CO2 level builds up and overrides the conscious part of your brain that's saying, don't breathe, and makes you inhale. The level of CO2, when it gets up to a certain point, you will inhale whether you want to or not. The people that do free diving, where they basically hyperventilate, you think, well, they're trying to get as much oxygen into their blood as possible. They're trying to blow off as much CO2 as possible. In the blood, you're worried about all three of them. Any changes in any of the three of those characteristics will stimulate the respiration. But in the brain, it's mainly the level of CO2, which is kind of weird. All right, hypercapnia is too much CO2. So as the CO2 level begins to increase for whatever reason, you're holding your breath or those the central and peripheral chemoreceptors are stimulated. That sends signals into the DRG. And what's the DRG do? Makes you inhale. Exactly. Bringing more air in, and you are bringing more oxygen in, but the key here is you're able to exhale more CO2, and the CO2 level drops. Hypocapnia is low CO2. And so what happens here is, as the CO2 drops, less of these receptors are stimulated, fewer signals are sent to the DRG, you don't inhale as deep. So you're retaining, you're not breathing in and out as much, you're retaining CO2, and that brings the CO2 level back up. All right, so those are the chemoreceptors. Now, baroreceptors, again, measuring blood pressure. Same 3 baroreceptors, nothing new here. Right atrium, aorta, carotid artery. If blood pressure increases, what happens is more blood flow is going back to the right atrium. So you're getting more signals here, because more blood is going through the heart, so pressure's going up. Increased signals from the baroreceptors says that heart slow down. You're pushing too much blood. At the same time the heart rate decreases, you're going to get peripheral vasodilation. That's going to lower the pressure. And we know that as soon as the heart rate goes down, so does respiratory rate. Respiratory rate goes down, heart rate goes down. The opposite is, if you're not getting enough pressure, not getting enough signals matching on those baroreceptors, not enough force on those baroreceptors, then those decreasing signals says, uh-oh, we need to pump more blood. So the heart rate's going to increase, and therefore so will the respiratory rate. All right, so we talked about local control, we talked about systemic control, we talked about the reflexes due to changes in blood pressure, as well as changes in blood and CSF chemistries. Then you've got stretch receptor reflexes. These are stretch receptors that are basically in the walls of the lungs. Now, everybody inhale. Keep inhaling, keep inhaling. At some point you got to exhale, right? So, this prevents you from actually blowing out your lungs. You cannot overinflate your lungs consciously. Same thing with, you cannot collapse your lungs. Everybody exhale till they can't exhale anymore. You cannot collapse your lungs. Protective reflexes. We talked about the carina, the inside where the trachea comes down and the right and left bronchi split off, primary bronchi split off. Right on the inside of that is a little sensor, a little thing that detects anything that gets down there. So that causes coughing. Of course, anything that tickles your nose is going to cause sneezing. You can have laryngeal spasms. I used to have a friend that would get those and it would just about close off his windpipe. Some people are allergic to certain chemicals or toxins, or fumes can cause the larynx to spasm. And so it's trying to prevent stuff from getting out in your lungs, but if it completely cuts off the airway, you've got a problem. And then conscious control. You've got all this information, the cerebral cortex, the emotional part of your brain, the hypothalamus. All of this stuff is sending signals into the pons and the medulla, controlling basically the pneumotaxic, apneustic, and the DRG and the BRG. And so we do have some ability to control breathing. And again, like I said, up to a certain point, if you hold your breath, you will eventually pass out and start breathing again. And of course, emotions control breathing. If you have a prolonged, dull, aching pain, that usually causes you to, you're just trying to grit through the pain. It's like when they have to do stitches or something, and they're doing the lidocaine. As opposed to if I stub my toe, I go. You ever notice that? Oh, good, because it usually keeps you from swearing sometimes. Why is this up there? Stretching the anal sphincter muscle. What in the world? If a baby's born and it's not breathing well, they can actually insert a finger into the anus, and for some reason that stimulates the respiratory system. try this at home.